and in my talk I'll be talking about evaluation and management of patients with dry endophthalmic socket syndrome. In the interest of open disclosures, I have commercial relationships with these entities. I will be talking about several devices manufactured by several of the companies and also distributed by them, but otherwise all other commercial relationships have been mitigated. As we've heard from many of the previous speakers, patients who face endophthalmic surgery have a very life-changing and significant event, and there is very significant psychosocial burden on patients. In view of the significant changes that patients experience, smaller things, although significant, such as that of endophthalmic socket discomfort, may be trivialized by both patients and also practitioners. When we think about socket discomfort, there are multiple risk factors that may result in discomfort, including that of a dry endophthalmic socket. And in looking at multiple studies that have been published, more than 60% of endophthalmic patients do experience symptoms that are suggestive of dry endophthalmic socket syndrome. And so it's important for us to be able to pick up, identify, evaluate, and manage these patients. But to do so, we really need to fall back on the definition of what DES really means. And Rocco and colleagues have proposed that dry endophthalmic socket syndrome is a disease of the socket surface that's characterized by a loss of tear film homeostasis and accompanied by socket discomfort. And this is a very long definition, but not one that we are unfamiliar with, because it leans very heavily on the definition of dry eye disease that's been put forth by the Tear Film and Ocular Surface Society in their Juice to Workshop reports. And so if we think about the ocular surface and we fall back on the extensive research in dry eye disease, we know that the precorneal tear film helps to support really two different interfaces, that of the bulbar conjunctiva and the cornea, and also that of the tarsal conjunctiva. But in an endophthalmic socket, with putting in a prosthesis, much like placing a contact lens in the front of the eye, the prosthesis splits the tear film into a pre- and post-prosthesis tear film, and there are now double the number of interfaces that this tear film services. So in trying to achieve a diagnosis of DES, it really is a combination of symptoms and clinical anomalies. The clinical anomalies that have been proposed will include that of a reduced tear meniscus height, significant conjunctival inflammation, either anterior or posterior blepharitis. And symptoms can be quantified using dry eye symptom questionnaires, and there are recommended cutoff scores in the literature with which to diagnose DES. It's important for us to note that some of these questionnaires do contain items assessing for visual quality and acuity, such as the OSDI, and so it's really important to take those things into account. And frequently it's important to administer the questionnaire twice, so one to the endophthalmic side and two, and the second time for the healthy eye, and having patients being able to discriminate between symptoms on either side. These are just some symptom questionnaires, some examples of symptom questionnaires that we've put on the slide itself. A few caveats in treating DES being that dry eye symptoms have a significant overlap with a wide range of conditions, and it's really prudent and important for the practitioner to rule out other conditions to be able to achieve a diagnosis of DES. We're all familiar with the slit lamp evaluation. There are a few nuanced differences compared to examining the healthy side or the healthy eye, and that being that the tear film breakup time can change, and a lot of, consideration has to be made, and we'll talk about that a bit later, about the prosthetic material, because many of the materials, if they're hydrophobic in nature, do not hold on to water, and that can lead to consequences pertaining to surface interactions and also other aspects such as the tear film coating the various surfaces. And the prosthesis fit and surface condition is something that we need to focus on. So sometimes blepharitis, we take a cursory look at the lids and the margin, but blepharitis is a very common condition, and sometimes it's there in front of us, but it's not evident unless we actively look for it, having the patient look down. And this is one of my patients who has quite active blepharitis. We can see signs of chronic changes with the presence of poliosis of the lid lashes. You can see some of the broken lid lashes, and we can see collarettes that are present. And when we perform mammography, we can see that the side of the lids has got significant meibomian gland fallout compared to the contralateral side. We have a dedicated mammographer, but in streamlined clinics in a pinch, you can actually use your AutoRef machine, which is able to capture images using the infrared camera. That only gives us a portion of the story. Meibomian gland structure is part of the story, but we really need to understand its function. So Meibomian gland expressibility is the other aspect to consider, and that's done using a pair of forceps, be it a fit for purpose or even Q-tips or cotton buds are useful in trying to understand whether the meibum is thick, viscous, how much pressure needs to be applied before we're able to express any meibum, if any. And you can see that in this patient here, there's evidence of meibomitis, there's the presence of dyssychitic lash, and when you squeeze in the lid and the patient was in a significant amount of discomfort, the meibum that was expressed was thick and viscous. Conjunctival inflammation can be evaluated using a variety of different scales, be it verbal descriptive scales such as this, or even pictorial scales. It's important to note that there are some papers that have demonstrated that DES manifests in patients not so much based off the severity of the conjunctival inflammation, but rather the duration of inflammation. And that has significant consequences because it really brings home the point that we really need to actively treat patients from the get-go with lubricants to bring down the inflammatory drive, to allow patients to be as comfortable as possible for as long as we possibly can. One other aspect that's quite familiar to dry eye specialists and contact lens practitioners, but I've scoured through the literature, did not find it in the DES literature, is a concept of lid wiper epitheliopathy. And that very prominent line that we see there is the line of Marks. The staining that we see inferior to that is really the lid wiper region, and it represents friction within the system itself. And if you imagine if the prosthesis is hydrophobic in nature, it's not able to hold on to water, that the lid and prosthesis interaction can result in a significant amount of friction, and that can ultimately manifest with lid wiper epitheliopathy. With the prosthesis itself, it's important for patients to present to the ocularist for regular checks, for polishing, and also to ensure that it fits really well. And in addition to that, surface deposits can form on the prosthesis, and there are various grading systems to look at surface deposits, and this is with a plaque disclosing gel. Dr. Sachin gave us a very nice talk, and he did mention that rose bengal can also be used to stain the surface of the prosthesis to look for presence of surface deposits. In addition to that, there are other nuances in terms of our examination that, in a busy clinic, it's easy to overlook. So blinking is really important to allow the tears to move, to allow the physiological movement of tears on the ocular surface or on the surface of the socket. And there are fit-for-purpose instruments that may be present, right, such as the Topcon Maya, or we are also developing a proprietary in-house algorithm that allows you to assess the patient's blink rate in real time using a smartphone camera. And there are other evaluation pointers, including that of tear film osmolarity, inflammatory cytokine analysis, and also assessing the prosthetic material types. And I was really enthused when Dr. Sachin did mention that there are also hydrophilic materials that are coming on market right now, right, to improve comfort of patients. And the osmolarity can be measured using the tear lab machine, and also Inflammadryer, which makes a lateral flow assay, allows us to assess the inflammation or inflammatory markers within the tear film itself. Just very briefly, moving on to treatment, there are a wide range of treatment options available in the treatment of patients with a dry surface, right? And these include lubricant drops and also anti-inflammatory drops. And even within the realm of lubricant drops, there are a range of ingredients that we can consider in the treatment and replenishment of the tear film. I will be focusing mostly on in-office treatments. And so microblepharoid exfoliation is it's been around for a while, and it's really quite effective. It helps to remove accumulated debris from the eyelid surface, and there is essentially a spinning sponge, and we use a cleaning solution to clean the lids. And this is one of my colleagues who is helping to do it for one of our patients, and we try to provide a nice spa experience, hence the music in the background. Okay? And one aspect that I've been quite excited about and have used it quite extensively in a wide variety of patients with surface problems is photobiomodulation. And it really uses near-infrared light, and the proposed mechanism really is at the cellular level. And if we look at its application across other disciplines, not just within ophthalmology, but within the rehabilitation of patients in physiotherapy, in dermatology. It's reported to reduce inflammation, to promote wound healing, and also relieve pain. And there are also no unfavorable safety reports for ocular surface use. And in a systematic review and meta-analysis that our team has recently resubmitted for publication, we've amalgamated 12 different studies, and it's demonstrated that a combination of low-level light therapy with IPL has led to improvements across a range of parameters that were sustained over a 6-month period. So I just wanted to show a little bit about what the treatment is like. So this is myself and 2 of my surgical colleagues coming in for treatment, and there's really little to no downtime. Right? And we also used it on a young little girl with surface issues, and she was able to tolerate it very well. Actually, the younger children tend to tolerate it better than the adults who whine quite a bit. And that's her dad patting her, because she insisted that dad be around and pet her while she was resting. So that brings me to the end of my talk. I think it's really important for us to consider a wide range of issues in assessing the socket. Aggressive management of conjunctival inflammation and adnexal disease may assist with long-term control of DES symptoms, and a range of therapeutics do exist to optimize ocular surface management. I'd like to acknowledge my seniors in